Good morning, everyone. Thank you so much. Thank you, the organizing team of AMA, for the invite and warm hospitality. Without wasting much time, we'll get into it. And thanks to our visionary chairman, who is a practicing neurosurgeon, who thought for the movement disorders this will be the future of neurosurgery, and he got the system in India for the very first time. And this is our training completion certificate for all the our MRGFUS team from the Insight so that we can independently handle all the treatments. So it's a treatment option for patients with essential tremors or Parkinson's disease who haven't responded to medication or are not willing to have an invasive surgery. The procedure uses focused beams of ultrasonic energy guided by the MRI to target areas deep in the brain, especially the thalamus, and there is no incisions, no permanent implants, and no anesthesia. And when you look at the timeline of the development of HIFU, you can see during the early 1990s, there was the invention of ultrasound phased array elements and the MR thermometry, which lead to the development of the first MR guided focused ultrasound system by Insight in 2000. And after the randomized control trials for essential tremors and Parkinson's disease in 2016, the FDA approved it. And subsequently in 2018 and 2021, FDA approved it for using in tremor dominant Parkinson's and in even advanced Parkinson's disease. So how it does, it's a single session, incision-less transcranial ablation in the region of interest, delivering ultrasound waves. The targets include ventralis intermedius nucleus for tremors and pallidothalamic tract for bradykinesia and rigidity. We use a 3 Tesla MRI scanner and Insight exablate neuro system. The patient will be awake during the entire procedure, which may take 2 to 2.5 hours. Initial temporary sonications with a mean temperature of 48 to 50 degrees are done as test sonications to evaluate on-table clinical outcome, and followed by sonications with a mean temperature of 52 to 54 degrees, which creates a permanent lesion in the brain. And this is our system, and this is how the Insight system is integrated with the 3 Tesla MR. And this is the helmet-shaped transducer, which houses 1024 elements and which operates at a frequency of 650 kilohertz. And its advanced focusing algorithms creates a precise focal spot of 2 to 4 mm. This is the external cooling system, which is kept outside. And treatment options for movement disorders include medical management and surgical management. When you look at the ablative procedures, there are stereotactic radiosurgery and radiofrequency, which are not done much. And the MR guided focused ultrasound system has taken over the treatment of movement disorders entire worldwide. More than 25,000 procedures has been done since 2016, and it's gaining popularity more and more every year. The other surgical option includes deep brain stimulation, which is an invasive procedure. So this is how, as Srinivasa said, the frame is fixed above the head by using 4 screws, 2 in the front and 2 at the back, and a membrane is placed over it. And you can see this how the patient is placed in the MR gantry. So they have to lie comfortably for the next 2 hours, and they'll be in communication with us, and our team will be talking to every now and then. One important aspect is the skull density ratio. Skull is
Sir, 5 minutes more.
Skull is an important barrier for ultrasound traversing into the brain. So when you look at it, the ranges ranges from 0.4 to 0.7 is the normal range. When the skull density ratio is more than 0.5, there is an excellent ultrasound penetration. When it is less than 0.30, there is a poor penetration, and the risk of skull heating can happen. So higher the SDR, only less joule energy is required to make a lesion. That's important. Lower the SDR, high energy joule requirement is more. So we have done a study on our Indian population where our skull density ratio, the mean ratio is 0.56, which is very excellent to treat. As I said earlier, the nucleus which we target is VIM, which has the dentoto-rubrothalamic tract, which acts as a connection between the areas that regulate tremors. So determining the VIM location is very difficult. Even a 3 Tesla MR will not show the image, and there are methods to calculate how we do it using the pre-planned pre-procedure planning. These are the targets which we draw, and then we make safe areas like internal capsule are marked. The treatment process includes patient preparation, planning, target verification, treatment, and assessment. So we have 4 phases. The align phase, we just check how the lesion is created, and in the verify phase, we check for the clinical assessment, and at treat low phase, we create the permanent lesioning. This is how it looks when you get in the verify phase. It is very well within the exact location, and this is the treat low phase where the permanent lesion happens. So this is targeted BIM areas, and you can see the lesioning happening, and even in the pallidothalamic tract and subthalamic nucleus, you can see the lesions are created, and posterior subthalamic area, the lesions. So what we do during the procedure and post-procedure, we do imaging, again a T2 weighted image, which gives us the area where we have targeted and the lesions, how it happens. So post MRGFS day 1, you can see there is a central area of necrosis followed by the circumferential cytotoxic and vasogenic edema, which gets resolved. And this is example of taking immediately after the procedure. And this is our first procedure done on a patient on 8th of August 2022. He was suffering from Parkinson's disease for more than 15 years, and he was not able to do his day-to-day activities. And the first thing after writing on his phone. So this during the our neurologist evaluate, and this how it happens. And one example to show a 46-year-old male tremor dominant Parkinson's patient for more than 8 years, an entrepreneur from Dubai with a marked hypokinesia and severe drug-induced dyskinesia. And you can see the drug-induced dyskinesic movements, and you can see the tremors, as well as in the jaw also you will be able to see the tremors. There is some slowness in initiation, and this is how the MRGFUS, the lesion has been created. And immediately the same night, he was able to use his own hands to take his food, which he was not able to do it priorly. And the next day, in the morning, he was jogging along our corridors. And this is one more patient with cervical dystonia and Parkinson's. And immediately after the treatment, this thing got cleared. And this is our, last week we did a patient from South Africa. There is, you can see, there is difficulty in pouring the water. And immediately after the procedure, she'll be able to do it without any disturbance. This is even taking on her own. That will be very difficult, in which she cannot do it. And she was able to do it immediately. So you can see, this is the pre-procedure and the post-procedure, her writings. And this is one of our patients who gifted us after painting. And the future, even though we are doing it for movement disorders now, we have done our India's first obsessive compulsive disorder patient also. And the future happens for blood-brain barrier breakage, which there is a new modality. There are variants like high intensity, which we use this, and there is a light.
Time is over.
1 minute, I'll just finish it up. There is a low intensity focused ultrasound system is coming up, which works in the means of neuromodulation. And there are other things happening for focal epilepsy. It's coming up in a very big way, and gelastic seizures also, and medial temporal lobe seizures also. There are case reports started happening. So in conclusion, so far we have completed more than 250 patients. 20% were essential tremors, and 80% patient of the patients were Parkinson's disease, which includes dystonic and SEA12 patients. We have a follow-up of 43 patients in our context. And there are no major complications, only there are minor complications like transient ataxia, dysarthria, weakness, and somnolence, and headache, which gets resolved within 2 weeks to 2 months time frame. There's nothing much. So in transforming movement disorder care, it is a very precise and safe, high degree of patient acceptance. All age groups from 28 years to 93 years we have treated. It is safe across and future. This is our team. And thank you for the patient listening.
Thank you, sir.